Good morning, students. In the previous class, we had discussed. हाँ मैं तेज बोलेंगे AC धीरे कर दीजिए थोड़ा. In the previous class, we had discussed anticoagulants. Um, we had discussed about heparin, low molecular weight heparin, and oral anticoagulants like warfarin, and other newer oral agents like dabigatran, rivaroxaban. So apixaban. So today we have discussed this part of there's a three-pronged approach in controlling the thrombus or the embolus. One is by anticoagulation. So we have discussed the drugs that are used in anticoagulation. Like heparin, low molecular weight heparin, warfarin, etc. So these drugs are effective in the prevention and treatment of thrombosis in the venous and arterial system. The second arm is the antiplatelet drugs. They are usually given for the secondary prevention. And the third arm are the fibrinolytic or the thrombolytic agents, which have a direct action in dissolving existing thrombus and are used for the acute treatment of thrombosis, namely the treatment of acute MI, acute ischemic stroke, massive pulmonary embolism. So, whereas these antiplatelet drugs are they are considered for prevention, as antiplatelet drugs are generally only considered for arterial or intracardiac thrombosis, as these thrombi are rich in platelets, while thromboemboli in the venous system have a relatively low platelet content. So this is another important thing one has to keep in mind when using antiplatelet drugs. They are more effective when these thrombi are forming in the arterial system rather than the venous system. So we will be discussing about the antiplatelet drugs now. So what is platelet? You all know what is platelet. Platelets are responsible for forming a platelet plug. Initially, whenever there is physical trauma to the vascular system, example, there is injury or puncture in the vessel, this triggers a complex series of interaction between the platelets, the endothelial cells, and the coagulation cascade, which ultimately leads to hemostasis or the cessation of blood loss from a damaged blood vessel. So, initially there is vasospasm of the damaged blood vessel. This vasospasm prevents further blood loss, and then there is formation of a platelet fibrin plug at the site of the injury. So we had when we were discussing the anticoagulants, we discussed the cascade. So intrinsic pathway, the extrinsic pathway, and how they converge together, ultimately activating factor 10A, which will activate thrombin formation, and thrombin will initiate formation of conversion of fibrinogen to fibrin. So in between the fibrin that is being deposited, the platelets will get enmeshed, and there is formation of a platelet fibrin plug. So this is going to block further blood loss from the site of injury. But when this thrombosis occurs in a pathological way, that is when it is not wanted. For instance, when it is happening inside, say, a cerebral vessel or coronary vessel, or it is happening in the So then unwanted thrombus formation is unwanted, and it can block the arteries, compromising the blood supply to the organ. So unwanted thrombus formation involves similar steps as normal clot formation. So whatever steps are being used up for physiological clot formation, same steps are involved in the triggering of the pathological um, clot formation. Usually, um, there is usually the main pathology usually is underlying atherosclerosis, and atherosclerosis makes the endothelium lining um, it damages the normal endothelial lining, exposing the subendothelial layer. Now, subendothelial layer can now trigger formation of clot. So, the triggering stimulus in the pathologic condition is a pathologic condition in the vascular system. Like I mentioned, atherosclerosis may be there, rather than external physical trauma. So platelets, when there is no trigger, they are just circulating freely in the blood. So in the absence of injury, resting platelets, they are circulating freely, and the endothelial cells synthesize prostacyclin I2, which acts as an inhibitor of platelet aggregation. So all the blood vessels, they are lined by endothelial cells. Only when the endothelial cells are healthy, they synthesize a prostaglandin I2, which is called prostacyclin, which acts as an inhibitor of platelet aggregation. So there is laminar flow, and also the endothelial cells are synthesizing prostacyclin. So platelets don't adhere to the vessel wall underlying, and they move freely. So what is prostacyclin doing? It binds to the platelet membrane receptors that are coupled to the synthesis of cyclic adenosine monophosphate, an intracellular messenger. So prostacyclin elevates the level of intracellular cyclic AMP, and when this level of intracellular cyclic AMP is high, it leads to decreased intracellular calcium, which prevents platelet activation and the subsequent release of platelet aggregation. uh, and Sorry, there is a mistake in typing here. So elevated levels of intracellular cyclic AMP leads to decreased intracellular calcium, which prevents platelet activation and release of, yeah, it's okay, and it's release of subsequent release of platelet aggregation agents. So there are many mediators which are stored in the platelets. So once the platelet is activated, it will release all these stored mediators. So these stored mediators are called platelet aggregation agents. Examples: thromboxane A2, which is a very powerful platelet aggregation agent. So damaged endothelial cells. So what happens when the endothelial cells are damaged? When they are damaged, they will synthesize less prostacyclin than the healthy cells. So thus less prostacyclin binds to the platelet receptors and less cyclic AMP is synthesized, and this leads to platelet aggregation. So there is a very important interplay between the healthy endothelium and the platelets. Till the time endothelium is healthy and it is lining the vessel wall smoothly, the flow of blood is laminar, there is no local turbulence, and also prostacyclin synthesized by the endothelial cells is going to uh, inhibit platelet aggregation. So platelets are not activated, and they are just circulating freely in the blood. So platelet membrane contains receptors that can bind thrombin, thromboxanes and exposed collagen. So exposed collagen, when the endothelium layer is denuded, the underlying subendothelium is exposed, and the platelets can now recognize this collagen and can bind to it because they have specific receptors. So in the intact normal vessels, circulating levels of thrombin and thromboxanes are low, and the intact endothelium covers collagen in the subendothelial layers. So no platelet adherence will occur and no platelet activation will occur. So thus the corresponding platelet receptors are unoccupied and there is no platelet activation and aggregation. But when the endothelium is injured, platelets adhere to and virtually cover the exposed collagen of the subendothelium, and once they attach to the underlying collagen, they trigger a complex series of chemical reactions which we call platelet activation. What happens in platelet activation? Receptors on the surface of the adhering platelets are activated by the collagen of the underlying connective tissue. So the various receptors for various mediators like thromboxane, ADP, they are now expressed, they are exposed on the surface of the platelets once they bind to the connective tissue which is now exposed on the vessel wall. So binding to this activation of these platelets causes morphologic changes in the platelets and the release of platelet granules, and there is further release of platelet granules containing chemical mediators such as adenosine diphosphate ADP, thromboxane A2, serotonin, platelet activation factor and thrombin. So many mediators, different types of mediators are released, and these mediators bind to the surface receptors on the resting platelets circulating nearby. So some platelets have already adhered and they are activated. They start releasing these mediators. These mediators will now go and activate and attract circulating other circulating platelets which are in circulation. So these receptors function as sensors that are activated by the signals sent from the adhering platelets, and mainly these actions are mediated by several messenger systems which ultimately result in elevated levels of calcium and a decreased concentration of cyclic AMP within the platelet. If you remember, prostacyclin was increasing the concentration of cyclic AMP, and when the platelets are activated, there is decreased concentration of cyclic AMP within the platelet. So once the concentration of cyclic AMP is decreased, there is increase in the level of calcium, which increases the release process of many of these mediators stored inside the platelet. And these mediators like ADP, thromboxane A2, serotonin, they go and further bind to the receptors of other platelets and triggering a chain reaction. So there is increase in the cytosolic calcium due to activation, and this leads to release of platelet granules containing mediators such as ADP and serotonin, which also activate other platelets. Now there is activation of thromboxane A2 and activation of glycoprotein 2B3A receptors that bind fibrinogen and ultimately regulate platelet-platelet interaction and thrombus formation. So what is platelet doing ultimately? What is this activation of platelet finally leading to? It is leading to the activation of this receptor, glycoprotein 2b3a receptors on the surface of the platelet. This receptor can bind fibrinogen and this fibrin, then the formation and the binding of this fibrin between two different platelets will lead to cross linking of the platelets. So we have a figure. We will now discuss, look at this figure and discuss. You see, this is the intact endothelium, but when the endothelium is denuded, it is exposing the underlying connective tissue. So the flow in this area is not laminar, it becomes turbulent. It causes addition of platelets to the surface, to the collagen. So this is a platelet. It has got receptors for various mediators like collagen, thrombin, ADP, thromboxane A2, and it has started releasing. You see, platelet activation occurs. First is addition. Addition occurs by binding of this binding between GP1B receptors and the von Willebrand factor. It stabilizes the platelet on the collagen on the vessel wall, and there is activation reaction. Activation reaction meaning now the levels of cyclic AMP are low, calcium inside the platelet is high. It has started releasing various stored mediators. All these mediators. So these mediators will not only will of course be activating these platelets are activated, but they're going to activate the nearby circulating platelets also. Now once these platelets are activated, they are bound to their various receptors. It is going to undergo a morphologic reaction. The platelets are no longer round. They become they change their shape, and the projections, many projections are formed, and the surface GP2B3A receptor is exposed. This is what we mean by morphologic change in the platelet. They are no longer round bodies. So platelets are still adhering to the vessel, underlying vessel wall collagen, and there is shape change, and this receptor GP2B3A receptor is exposed, and there is binding of fibrinogen strands. So GP2B3A receptors, they bind to this fibrinogen, and there is cross linking. So it may be that fibrinogen one end is binding to this platelet, other end is binding to this other platelet. So there is cross linking, and this web of cross linking forms a platelet plug, in which platelet and red blood cells, they get enmeshed. So this is what platelets are doing. And since platelets are very important in the formation of the clot, so antiplatelet drugs are going to play a very important role in the management of an arterial clot, in the prevention of a arterial clot formation. So we have drugs like acetyl salicylic acid or aspirin, which is, and other categories, P2Y12 antagonists. We have dipyridamole, and we have GP2B3A antagonist, GP or glycoprotein 2B3A antagonist. So aspirin is used widely in patients at risk of thromboembolic disease. P2Y12 antagonist is also beneficial in the treatment of and prevention of acute coronary syndrome and the prevention of thromboembolic events. Dipyridamole is also useful in the secondary prevention in patients following stroke, often in combination with aspirin. And GP2B3A antagonists are administered intravenously, and they are effective during percutaneous coronary intervention. So they are very expensive drugs and have to be used very cautiously, given intravenously, mainly for during interventional procedures. So we have in the antiplatelet drugs we have cyclooxygenase inhibitors like aspirin. This is the most important drug that we use, very commonly used. We have adenosine diphosphate or ADP receptor inhibitors like clopidogrel, ticlopidine. We have phosphodiesterase inhibitors like celestazole. We have glycoprotein 2B3A inhibitors like epsiximab, eptifibatide, tirofiban, adenosine reuptake inhibitors like dipyridamole. Well, let us see how aspirin acts. Aspirin is also known as acetylsalicylic acid. So aspirin inhibits thromboxane A2 formation. So aspirin is a cyclooxygenase inhibitor. So in the platelet, it inhibits the formation of thromboxane A2. Now, as you discussed, the thromboxane A2 is very important in inhibiting platelet activation and aggregation. So, if the thromboxane stores of platelets are inhibited, less thromboxane or no thromboxane becomes available, and therefore this activation of platelets will be, and activation and aggregation of platelets will be inhibited. So before we go to the next slide, let us understand here that when we give aspirin, which is a cyclooxygenase inhibitor, in the platelets it's going to inhibit the formation of thromboxanes, but it also acts on the in the endothelial cells are synthesizing prostaglandin I2. So in the endothelial cells it is going to inhibit synthesis of prostacyclin. Now endothelial cell has a nucleus, whereas platelets, they don't have any nucleus. So they are released into the bloodstream um, with a quota of enzymes, which quota of the cyclooxygenase enzymes, if it is blocked by aspirin, there is no way this platelet can synthesize fresh enzyme as it lacks the nucleus. So once inhibited, the cyclooxygenase is inhibited for the lifetime of the platelet. Now thromboxane A2 is responsible for platelet activation and aggregation, whereas prostacyclin synthesized by the vessel wall endothelium is also protective. So, but this production, although it is blocked by aspirin, the endothelial cells is able to generate new enzymes, synthesize fresh enzymes, and so prostacyclin synthesis is not much affected. So when aspirin is taken, it is rapidly absorbed. Absorption occurs in the stomach and upper intestine, and peak plasma concentration is achieved within 15 to 20 minutes after administration. Peak inhibitory effect on platelet aggregation is apparent approximately 1 hour post administration. Aspirin produces irreversible inhibition of the enzyme cyclooxygenase, and therefore causes irreversible inhibition of platelets for the rest of their lifespan. It is very important to understand this, that why aspirin is used in the NSAIDs, when only why aspirin is used and not other NSAIDs as antiplatelets, because aspirin is an irreversible inhibitor of cyclooxygenase, and it is very important that this enzyme cyclooxygenase is inhibited irreversibly, so that platelets are not able to synthesize thromboxane for the rest of their lifespan. Cyclooxygenase enzyme is required for the synthesis of thromboxane ultimately. So aspirin irreversibly inhibits the enzyme cyclooxygenase, resulting in reduced platelet production of thromboxane A2. Since we know that thromboxane is a powerful vasoconstrictor and it lowers the cyclic AMP and initiates a platelet release reaction, therefore less availability of thromboxane A2 is going to interfere and inhibit platelet activation and aggregation. Now, clinical uses of, I am mentioning here low dose aspirin. So the aspirin is effective in low doses, 75 to 150 milligram per day, and even in this low dose it is very effective in inhibiting the platelet cyclooxygenase, but it does not affect, it is with less side effects, less GI side effects, and less deleterious effect on the synthesis of prostacyclin also. So we always use a low dose of aspirin for its antiplatelet activity. Now this low dose aspirin is useful in the prophylaxis of MI, in the prevention of reinfarction and prevention of stroke. So secondary prevention of transient ischemic attack, ischemic stroke and myocardial infarction. Prevention of ischemic events in patients with angina pectoris, and prevention of coronary artery bypass graft occlusion. So mainly for secondary prevention and prophylaxis we are using low dose aspirin. So side effects associated with aspirin are risk of GI bleeding. Ulceration and bleeding is a very common risk associated with aspirin. Allergic reaction. It is not a very effective antithrombotic drug, but is widely used because of its ease of use. Lack of response in some patients is also seen. This is called aspirin resistance. And so of course we know that causes irreversible platelet inhibition. Dipyridamole is a drug which is inhibiting platelet phosphodiesterase, and this causes an increase in the cyclic AMP with potentiation of the action of prostacyclin. So dipyridamole is also increasing the cyclic AMP, and it is again synergizing with the prostacyclin and opposes the action of thromboxane A2. Uses of dipyridamole. Dipyridamole is usually given with aspirin for the prevention of thromboembolism after heart valve replacement surgery and used with warfarin. So ADP receptor antagonist, also known as P2Y12 receptor antagonist, So again, platelets which have adhered to the collagen, they express, in addition to the thromboxane receptors, they exhibit ADP receptors, which are um which are activated by ADP. So this is showing ADP, which is going to be released and which is going to activate. But now clopidogrel is blocking the ADP receptor. So this ADP cannot bind to the ADP receptor, and therefore platelet activation and aggregation is going to be blocked. So important drugs are ticlopidine, clopidogrel, others like prasugrel, canigrelol. So they are all ADP receptor antagonists, acting by blocking the ADP binding to the ADP receptors. So ticlopidine and clopidogrel, ticlopidine and clopidogrel, they are thienopyridines. They can be administered orally and absorption is very good, 80 to 90%. They are prodrugs and they have to get activated in the liver. So they are adenosine, ticlopidine and clopidogrel, they are adenosine diphosphate receptor antagonists. They are oral antiplatelet drugs whose effects are similar to aspirin. Again, aspirin is acting by blocking thromboxane A2 synthesis. They are acting by blocking the ADP receptors. So their mechanism is different. So used for prevention of ischemic stroke and MI. And what is the mechanism? Irreversible blockade of ADP receptors on the platelet surface. This receptor is P2Y12 purinergic receptor. So when this is blocked, um, this receptor actually, once activated by ADP, is going to mediate adenylyl cyclase inhibition by ADP. So once this is blocked, it is going to interfere with the platelet activation. So it is synergistic effect with aspirin, as it has a different mechanism of action. So aspirin is acting by inhibiting synthesis of thromboxane A2, whereas these drugs are acting by blocking the ADP receptors. Thrombocytopenia is an important side effect with ticlopidine. So ticlopidine is well absorbed orally. It is converted in liver to an active metabolite, as this is a prodrug. Eliminated with a plasma T-half of 8 hours. It has a peak antiplatelet effect produced after 8 to 10 days. Plasma T-half after single dose is 8 hours, and after multiple doses it is 8 days. The common side effects are diarrhea, vomiting, abdominal pain, headache, tinnitus, skin rash, bleeding, neutropenia, thrombocytopenia, hemolysis, jaundice. It is given in the dose of 250 mg twice daily with meals. Now, clopidogrel is a safer and better tolerated drug as compared to ticlopidine, so it is very commonly used now over ticlopidine. It is a prodrug and approximately 50% of the oral dose is absorbed. It is slowly activated in liver by CYP2C19. It is important to remember that it requires CYP2C19 because of two reasons. That CYP2C19 exhibits genetic polymorphism. So activation of clopidogrel and also its antiplatelet activity shows high inter-individual variability. So one reason is this. And another is that if a patient is prescribed drugs like omeprazole, which inhibits CYP2C19, then it is going to reduce the metabolic activation of clopidogrel and reduce its antiplatelet action. So omeprazole has to be avoided when clopidogrel is given. The antiplatelet effect of clopidogrel takes about 4 hours to start and develops over a few days. An antiplatelet action lasts for 5 to 7 days after discontinuation of the drug because it blocks the platelet P2 vital receptors irreversibly. The side effects associated with clopidogrel are bleeding, rarely neutropenia, thrombocytopenia, and bone marrow toxicity, diarrhea, epigastric pain, and rashes. The dose is 75 mg once daily. So I've already mentioned that they're used for secondary prevention of ischemic complications after MI, ischemic stroke, and peripheral arterial disease. Secondary prevention of ischemic complication in patients with acute coronary syndrome without ST segment elevation. So clopidogrel is only slightly more effective than aspirin. As with aspirin, clopidogrel binds irreversibly to platelets. In some patients, resistance to clopidogrel has also been seen. Another drug in this category is P2 vital blocker is prasugrel. It is very potent and faster acting. It's also a prodrug. It is more rapidly absorbed as well as more rapidly and completely activated, resulting in faster and more consistent platelet inhibition. CYP2C19 metabolizes prasugrel as well, but the effect of genetic polymorphism or omeprazole is not prominent as in the case of prasugrel. Dose is 10 mg once daily. Bleeding complications are more frequent and more serious. Patients with history of ischemic stroke and TIAs are at greater risk of intracranial hemorrhage. So we have to be careful when we are giving prasugrel. It is useful in STEMI, angioplasty, and when strong antiplatelet action is required. Coming to the next category, GP2V3A receptor antagonists. These are very powerful agents, very powerful drugs, very powerful antiplatelet drugs, because the ADP, we've discussed activation of platelets by ADP and thromboxane A2. Ultimately, platelet activation is going to lead to morphologic change, and the activated platelets are going to exhibit GP2B3A receptors, which are going to be binding fibrinogen. So, network of fibrinogen with strands binding here and there to different GP2B3A receptors, cross linking is going to be there, and this is the ultimate action of platelet activation. So if we have drugs which block this receptor, then we have then no cross linking of fibrinogen will take place, and we will have we will achieve total antiplatelet activity. So glycoprotein 2B3A receptor antagonist, the mechanism of action is reversible blockade of platelet GP2B3A receptors on platelet surface for fibrinogen and von Willebrand factor. The blockade of this receptor ultimately antagonizes platelet aggregation by other agents. It could be any agent. It could be collagen, thrombin, Rhomoxin A2, ADP also, as this is the final step in platelet aggregation. So therefore these are also known as super aspirins, and they are the most effective antiplatelet drugs marketed. They are used only intravenously. Abciximab is a GP2B3A antagonist. It is actually a chimeric monoclonal antibody. It is the FAB fragment of chimeric monoclonal antibody against the GP2B3A. This abciximab is the first agent which was approved in this class of drugs. It is used along with aspirin and heparin during percutaneous coronary intervention and in acute coronary syndromes. It markedly reduces the incidence of restenosis, subsequent MI, and death. Platelet aggregation remains inhibited for up to 12 to 24 hours. And the dose that we use is 0.25 milligram per kg intravenously 10 to 60 minutes before PCI, followed by 10 microgram per minute for 12 hours. So it's non-antigenic but very expensive, and it is associated with a high risk of hemorrhage, thrombocytopenia, constipation, ileus, and also arrhythmias. Heptafevertide has same mechanism of action as abciximab, longer plasma T-half, but platelet inhibition reverses in a shorter time as it quickly dissociates from the receptor. Bleeding and thrombocytopenia are the major adverse effects. Rash and anaphylaxis are rare. Tirofiban is similar with a plasma T-half of 2 hours, and it also dissociates rapidly from the receptors. So after antiplatelet drugs, let us discuss the thrombolytic drugs. The thrombolytic, we have discussed the anticoagulants, we have discussed antiplatelet, and now the thrombolytic drugs. As the name implies, thrombo is that they are going to lyse the thrombus. So drugs like aspirin, low molecular weight heparin, warfarin, other oral anticoagulants, they were preventing further formation of clot. Antiplatelet drugs was preventing activation of platelets and triggering of the clot formation. So they are used for secondary prevention, whereas these are the only drugs which can lyse the clot which has already been formed. So physiologically it is we have the plasmin. The plasminogen is converted to plasmin, and plasmin is the one which lyses the fibrin strands in the clot to fibrin degradation products, and also D dimers are formed. So this is what thrombolytic drugs are doing. They are activating conversion of plasminogen to plasmin, and activating this plasmin which is formed is now going to lyse the fibrin to fibrin degradation products. So they bind with plasminogen to form a complex that acts on molecules of plasminogen to convert it to plasmin to digest fibrin meshwork of clot. They are very effective in dissolving thrombus immediately. Thrombolytic drugs. They are used in medicine to dissolve blood clots. This is a procedure which is called thrombolysis. Thrombolytic drugs include tissue plasminogen activator, TPA, like LTPlase, retiplase, tenecteplase. Other fibrinolytics like streptokinase, urokinase, anistriptase. So thrombolysis in patients with acute myocardial infarction and thrombolysis in patients with ischemic stroke. So these are the indications. Thrombolysis of subacute peripheral arterial thrombosis. The thrombosis in patients with acute massive pulmonary embolism. Thrombolysis of occluded hemodialysis shunts. So thrombolysis is used in MI, myocardial infarction, ischemic stroke, deep venous thrombosis, pulmonary embolism, to clear a blocked artery and to avoid permanent damage to the perfused tissue like myocardium or brain or leg, and then subsequently death. A less frequent use is to clear blocked catheters and are used in long-term medical therapy. But very important complication of thrombolytic therapy is bleeding. So hemorrhagic stroke is a rare but serious complication associated with thrombolytic therapy if bleeding occurs in the brain. If a patient has had thrombolysis before, an allergy against the thrombolytic drug may have developed. Now, this is very important, especially after the use of streptokinase. We'll discuss why. So, if the symptoms are mild, infusion is stopped and the patient is commenced on an antihistamine before infusion is recommended. Anaphylaxis generally requires immediate cessation of thrombolysis. So absolute active internal bleeding is a contraindication. Suspected aortic dissection, acute pericarditis, intracranial neoplasm, history of hemorrhagic stroke, and cerebrovascular accident within 12 months. Other contraindications are like severe uncontrolled hypertension, current use of anticoagulants in therapeutic doses, recent trauma, and recent major surgery. Now, all these are important. Others like recent internal bleeding, prior exposure to streptokinase if that agent is to be administered, that is 5 days or to 2 years in this period if it has been given. So pregnancy, active peptic ulcer, history of chronic severe hypertension, and age more than 75 years. So what happens is all these predisposed to increased risk of bleeding. So any recent surgery, any even uncontrolled severe hypertension, because it is a risk factor for stroke and known bleeding problems, so etc. So we want to rule out all the predisposing factors to which can predispose the patient to risk of bleeding. Now streptokinase is a thrombolytic drug. It is obtained from beta hemolytic streptococci group C. Now streptokinase combines with circulating plasminogen to form an activator complex, which then causes limited proteolysis of other plasminogen molecules to plasmin. So anti-streptococcal antibodies due to past infections can inactivate streptokinase because it is derived from beta hemolytic streptococci, and if the person has had prior streptococcal infection, so he can form anti-streptococcal antibodies, and this can inactivate streptokinase. So advantage of streptokinase is, although this is a very important problem, if the person has had prior infection, then it will be inactivated, but otherwise it is very cheap and opens arteries more slowly than the other agents. It produces profound hypotension and carries the risk of allergic reactions. And why allergic reaction again? Because again it is coming um, from the bacteria, and antibodies, if there are, first of all it will inactivate, and then there is also risk of allergic reactions. It should be avoided in patients who have received it previously, because if a person has received streptokinase once, his immune system will be sensitized to the antigen present in this streptokinase, and it will synthesize antibodies to it. So the second exposure to streptokinase will the circulating antibodies will neutralize it, and it will be ineffective. Urokinase is enzyme isolated from human urine. It is now prepared from cultured human kidney cells. This has a plasma T-half of 10 to 15 minutes. It is non-antigenic. It is useful in patients who have previously received streptokinase. Coming to tissue plasminogen activators. The advantages of tissue plasminogen activators versus streptokinase include thrombus specificity and faster reperfusion. So the advantages of tissue plasminogen activator versus streptokinase include thrombus specificity and faster reperfusion, with a slightly increased risk of bleeding and significant higher price. The risk of bleeding is much higher with TPA or tissue plasminogen activator, and they are very expensive as compared to streptokinase. But the advantage is that they have a thrombus specificity is there, and it can open up the blocked vessels faster. So why do we say that TPA is more thrombus specific? Because it can activate plasminogen already bound to fibrin and has little action on circulating plasminogen, whereas streptokinase just forms an activator complex irrespective of where the plasminogen is. It is free or circulating, or it is bound. So it is not differentiating, whereas TPA activates plasminogen which is bound to fibrin. So this will ensure that plasminogen gets activated to plasmin and lyses the fibrin plug to which it is bound. Intravenous heparin must be administered concomitantly with these agents, as it is seen that when we use these agents, there is risk of thrombosis. So it has to be covered up by giving intravenous heparin. So antiplase is rapidly cleared by liver and has a plasma T half of 4 to 8 minutes. It has to be administered by slow IV infusion. Altiplase is non-antigenic and the side effects include nausea, mild hypotension and fever. Ritaplase is longer acting. It is less specific for fibrin bound plasminogen but longer acting. The tenecteplase has higher fibrin selectivity and longer duration of action. Recent studies suggest that altiplase, tenecteplase and ritaplase with IV heparin are the most effective currently recommended medical therapies for achieving early coronary reperfusion, but they have a slightly greater risk of intracranial hemorrhage and are considered more expensive than streptokinase. So this is the advantage and disadvantage associated with this tissue plasminogen activators. Thus, the cost benefit ratio with these agents is greatest in patients presenting within 4 hours of symptom onset when the potential for myocardial salvage is highest. So this is the we will end our class here, and just to summarize again, so we have three arms. We have anticoagulants, we have antiplatelets, and we have fibrinolytics. So each arm has a uh, different approach. Anticoagulants, they are going to prevent formation of new thrombi, new clot. So thus they have anticoagulants. And the antiplatelets, they are going to prevent platelet activation. They are useful in secondary prophylaxis, very important when these events are taking place in the artery rather than in the veins. And we have thrombolytics. These thrombolytics, they are going to lyse the already formed thrombus. They are the clot busters. So, but they come with the disadvantage. Almost all of them have this disadvantage that they can cause increased risk of bleeding. So we have to monitor for that risk and assess the risk benefit ratio always. Okay, thank you very much.